Good morning, everyone, and thank you for being here today. I'm Dr. Asim Haseen, and I'm excited to kick off this presentation on infectious emergencies. Today, we'll be focusing on one of the most critical topics, sepsis and septic shock. Over the next few slides, we'll explore what these conditions are, how to recognize them early, and the best approaches for management. Let's get started. All right, let's look at this case carefully. We have a 69-year-old man with diabetes who's been admitted with suspected pneumonia. He's showing some concerning signs: confusion, low blood pressure at 92/58, a fast respiratory rate of 28 breaths per minute, and an oxygen saturation of 91% on room air. His heart rate is elevated at 112 beats per minute, and his lactate level is 3.1 mmol per liter. Now the question is, which finding best confirms the diagnosis of sepsis in this patient? Remember, sepsis is essentially a life-threatening organ dysfunction caused by a dysregulated response to infection. So, we're looking for signs that point to this systemic impact. Looking at the options, fever with leukocytosis can suggest infection, but it's not specific enough for sepsis. Positive blood cultures are very important, but they take time and aren't always immediately available. Elevated CRP is a marker of inflammation, but again, not definitive on its own. What truly indicates sepsis here is the presence of suspected infection combined with acute organ dysfunction. That's why the option, suspected infection with acute organ dysfunction, is the most accurate. It captures the critical aspect of sepsis, the infection causing significant organ impairment, which is evident in this patient's altered mental status, hypotension, and elevated lactate. So, in summary, identifying this combination, infection plus organ dysfunction, is key to diagnosing sepsis promptly and initiating life-saving treatment. The correct answer here is C, and I want to walk you through why that's the case. Sepsis is a life-threatening condition that occurs when there's organ dysfunction caused by a dysregulated host response to an infection. What's important to understand is that the key indicator of organ dysfunction is a change in the SOFA score, specifically, a score of 2 or more points. This can be reflected in clinical signs such as hypotension, which means low blood pressure, altered mental status, or hypoxemia, which is decreased oxygen levels in the blood. An important point to note is that, unlike some misconceptions, culture positivity, that is, actually growing bacteria or pathogens in a lab, is not required to diagnose sepsis. The diagnosis relies on signs of organ dysfunction, not necessarily on positive cultures. Understanding this helps us focus on the clinical presentation and organ function, which are critical in identifying sepsis early and managing it effectively. This aligns with the overall theme of recognizing and responding to sepsis promptly to improve patient outcomes. Let's take a look at this question. It asks us to identify which criterion confirms septic shock in a patient with urospsis who remains hypotensive despite receiving 30 ml per kilogram of crystalloid fluids. The patient's blood pressure is 80/40, and the lactate level is 4.8 mmol per liter. Now, the important thing here is to understand the criteria that defines septic shock. It's not just about being hypotensive, but also about evidence that indicates underlying tissue hypoperfusion and ongoing circulatory failure. Looking at the options, option A, persistent hypotension alone, is not sufficient to confirm septic shock. Hypotension can occur in many situations, but without other signs, it doesn't confirm shock. Option B combines need for vasopressors to maintain a mean arterial pressure of 65 mmHg or higher, along with elevated lactate levels above 2 mmol/L. This combination is key because it indicates that despite fluid resuscitation, the patient remains hypotensive and shows evidence of tissue hypoperfusion, which is characteristic of septic shock. Option C, positive blood cultures, confirms infection but doesn't alone confirm shock. Option D, oliguria alone, suggests kidney hypoperfusion but isn't enough on its own to define shock. And option E, fever over 39 degrees C, indicates infection but doesn't confirm the circulatory failure characteristic of shock. So, in this context, the most accurate answer is B. It captures the need for vasopressors and elevated lactate, both critical markers in confirming septic shock. This illustrates how we move beyond just identifying infection or hypotension and focus on evidence of ongoing circulatory compromise. All right, let's look at this slide. The correct answer here is B, and now I'll explain why. Septic shock is actually a specific subset of sepsis, and what makes it distinct are the profound circulatory and metabolic abnormalities that occur. To break it down, septic shock is characterized by the need for vasopressors to maintain a mean arterial pressure, or MAP, of at least 65 millimeters of mercury. Even with fluids, if the blood pressure remains low and vasopressors are needed, that's a key sign. Additionally, lactate levels are important here. A lactate level greater than 2 mmol per liter indicates significant metabolic disturbance and tissue hypoperfusion, despite adequate fluid resuscitation. This definition helps us identify patients with more severe circulatory failure, those who not only have infection and sepsis, but also show these specific hemodynamic and metabolic signs. It's a critical concept because recognizing septic shock early allows for prompt, targeted management, which is vital in improving outcomes. So, in summary, the key points are the need for vasopressors to keep MAP above 65, and elevated lactate levels indicating ongoing tissue hypoxia, even after fluids. These criteria really highlight the severity and complexity of septic shock within the broader context of sepsis. All right, let's take a closer look at this scenario. We have a 75-year-old man with septic shock, and importantly, he shows no signs of pulmonary edema. Now, when considering the initial fluid strategy in septic shock, the goal is to optimize perfusion without causing harm. So, looking at the options, the most supported approach is to administer 30 ml per kilogram of isotonic crystalloid within the first 3 hours. This strategy aligns with current guidelines, emphasizing early and adequate fluid resuscitation to restore circulating volume and improve tissue perfusion. In contrast, the other options, like giving just a 10 ml per kilogram bolus or starting with albumin first line, aren't generally recommended as initial steps. Restricting fluids and starting vasopressors immediately without sufficient volume can be risky, especially when the patient hasn't shown signs of fluid overload. The key point here is that early, carefully managed fluid resuscitation with isotonic solutions is crucial in septic shock management, especially in patients without contraindications like pulmonary edema. This approach helps improve outcomes by ensuring adequate tissue perfusion right from the start. All right, let's focus on the key points here. The correct answer is B, which emphasizes that in cases of septic shock, administering about 30 milliliters per kilogram of IV crystalloid fluids early on is generally recommended. This quick intervention helps support blood pressure and perfusion. It's important to remember that these fluids are the first line of treatment unless there's a specific reason not to give them. Now, if after giving these fluids, the patient still has low blood pressure or hypotension, then we add vasopressors to help constrict the blood vessels and raise the blood pressure. This stepwise approach, starting with fluids and then adding vasopressors if needed, is crucial in managing septic shock effectively. It highlights how early, appropriate fluid resuscitation is central to improving outcomes, and understanding when to escalate treatment with vasopressors is key. This ties into the overall theme of timely and targeted interventions in septic shock management. All right, let's look at this scenario. Despite giving adequate fluids, the patient with septic shock remains hypotensive. So the question is, which vasopressor should we start first? Now, among the options, dopamine, epinephrine, vasopressin, norepinephrine, and phenylephrine, our best initial choice is norepinephrine. Why is that? Well, norepinephrine primarily acts on alpha-adrenergic receptors, causing vasoconstriction, which effectively increases blood pressure. It's generally considered the first-line vasopressor in septic shock because it provides potent vasoconstriction with fewer cardiac effects compared to others. Other agents like dopamine or epinephrine have their roles but can have more varied effects, including increased heart rate or arrhythmias, which we want to avoid initially. Vasopressin can be added later as a secondary agent if needed, but it's not typically first line. Understanding the rationale behind choosing norepinephrine helps us stabilize the patient's blood pressure efficiently, which is crucial in managing septic shock effectively. So, the correct answer is D, norepinephrine. Correct answer is D now. Let's break down why. Norepinephrine is considered the first-line vasopressor in septic shock. The main reasons are its potency and the predictable effect it has on raising blood pressure. It also has a lower risk of causing arrhythmias compared to other agents. That makes it a reliable choice when managing septic shock. Vasopressin, on the other hand, isn't typically used right away. Instead, it's added later if needed, usually when norepinephrine alone isn't enough to maintain adequate blood pressure. Understanding this sequence helps us optimize patient management, using the most effective and safest options first, then adding other vasopressors as necessary. This approach aligns with the overall theme of evidence-based, targeted therapy in septic shock. Let's look at the options here. When a patient with suspected septic shock arrives in the ICU and cultures haven't yet been obtained, timing is critical. The key point is that we want to start treatment promptly to improve outcomes. Option A suggests waiting for culture results before giving antibiotics, but we know that delays can be detrimental. Similarly, Option B proposes delaying antibiotics until imaging is done, which might also waste precious time. Option D recommends starting antibiotics only if lactate exceeds 4 mmol/L, but that could delay necessary treatment in early septic shock. Option E talks about using narrow-spectrum antibiotics initially, but in septic shock, broad coverage is essential early on to target the likely pathogens effectively. That leaves us with Option C, giving broad-spectrum antibiotics within 1 hour after obtaining cultures, if possible. This approach aligns with the sepsis management guidelines, emphasizing early antibiotic administration, ideally within the first hour, because prompt treatment is linked to better survival rates. So the best approach here is to give broad-spectrum antibiotics quickly, ideally within that 1-hour window, to provide the patient with the best chance of recovery. All right, let's look at the key point here. The correct answer is C. Early administration of broad-spectrum antibiotics, ideally within the first hour of recognizing sepsis or shock, is crucial because it significantly reduces mortality. Time is really of the essence in these situations. It's also important to remember that obtaining cultures should not delay the start of antibiotics. You want to get the necessary samples quickly, but the priority remains initiating prompt antimicrobial therapy. This approach highlights how rapid, decisive action can make a real difference in patient outcomes, which ties back to the overall theme of timely management in sepsis and shock. Let's start by clarifying what we mean by sepsis. Sepsis occurs when an infection triggers a significant and potentially life-threatening response, leading to organ dysfunction. We often measure this using the SOFA score, which helps us gauge how severely the organs are affected. When this infection causes this kind of serious organ impairment, we classify it as sepsis. Moving on to septic shock, this is an even more severe stage. It happens when, in addition to sepsis, the patient develops low blood pressure that doesn't respond to usual treatments and requires vasopressors. Plus, there's an elevated lactate level, over 2 millimoles per liter, indicating that tissue perfusion is severely compromised. Understanding these definitions is crucial because they guide our management strategies. Sepsis can progress to septic shock, and recognizing these key features early can make a big difference in patient outcomes. Remember, the overall goal is to identify and treat promptly to prevent further deterioration. Let's talk about the immediate management during the so-called golden hour in sepsis and septic shock cases. First, ensuring oxygen and airway support is critical, because maintaining adequate oxygenation is a top priority right from the start. Next, blood cultures should be drawn promptly, but it's important to remember that this shouldn't delay the initiation of therapy. We need to start broad-spectrum IV antibiotics within the first hour to target the suspected infection effectively. Fluid resuscitation is also essential, so administering about 30 ml per kilogram of crystalloid fluid helps restore circulating volume. If after fluids, the mean arterial pressure remains below 65 mmHg, then norepinephrine is usually the vasopressor of choice to help elevate blood pressure. Our goal is to achieve a target map of at least 65 mmHg and to monitor lactate clearance, which indicates that tissue perfusion is improving. All these steps, oxygen support, early antibiotics, fluids, and vasopressors, are focused on quickly stabilizing the patient and preventing progression to multi-organ failure. This approach underscores the importance of rapid, coordinated action within that critical golden hour. Let's go over some key ICU points to keep in mind. First, avoid using dopamine when managing septic patients, because it can increase the risk of arrhythmias, which we definitely want to avoid. Instead, consider vasopressin as an add-on therapy if needed, but remember, it's not the first-line vasopressor. Early source control is critical. It can truly save lives by removing the infection source as soon as possible. Also, it's important to reassess fluid responsiveness dynamically, rather than giving fluids blindly. This helps us tailor fluid therapy to the patient's current needs. By focusing on these principles, we improve our management of sepsis and septic shock, optimizing outcomes and patient safety. Thank you so much for your time and attention today. I truly appreciate your engagement and interest. I hope this presentation has provided you with valuable insights and practical takeaways. Remember, the key points we discussed, whether it's about innovation, teamwork, or strategic planning, are all interconnected and essential to achieving success. If you take away anything, let it be the importance of applying these concepts thoughtfully in your own work. Once again, thank you for being such a great audience. I look forward to seeing how you implement these ideas moving forward.